Welcome. You're listening to The Deep Dive, where we cut through the noise and get straight to the vital information you need. Today, we're delving into a silent saboteur of success in orthopedic surgery: osteolysis.
Mm,
It's the microscopic enemy that, despite our most advanced implants, remains the single biggest reason patients often need to revisit the operating table for a second, often more complex joint replacement.
that's right. It's a major challenge.
This is a crucial challenge that directly impacts the longevity of implants and, most importantly, patient outcomes. We'll explore its fundamental science, the underlying mechanisms that drive it, and the cutting-edge strategies being developed to combat it. And to guide us through this intricate landscape, we have an unparalleled expert joining us today. It's a privilege to have you with us. Could you begin by framing for us what osteolysis truly is in the context of joint replacements? Why has this bone-resorbing phenomenon remained such a persistent concern for orthopedic professionals despite, well, decades of innovation?
Thank you. It's a pleasure to be here. And yes, it's a fundamental issue that has, as you rightly put it, plagued arthroplasty for decades. At its most basic, osteolysis is a radiographic term, meaning we identify it on X-rays or other imaging, denoting the loss of pre-existing bone around a prosthetic implant.
Okay, so it's primarily an imaging diagnosis initially.
Initially, yes, though the clinical consequences are what matter most. Its association with orthopedic implants was first recognized as early as 1975, although the clinical phenomena of aseptic loosening, which osteolysis drives, had been observed prior to that. Interestingly, in those early days, it was sometimes colloquially referred to as cement disease.
Cement disease, why that term?
Well, it linked it directly to fragmented bone cement, specifically polymethylmethacrylate, or PMMA. The initial hypothesis was that the cement itself, or perhaps its breakdown products, were somehow toxic to the bone.
Ah, I see, a direct material toxicity idea.
Exactly. But our understanding has evolved significantly since then. We now know it's a far more complex biological response, almost akin to a misguided immune reaction, if you like. It's often triggered by wear and corrosion debris generated from the implant itself.
So tiny particles coming off the implant components?
Precisely. These are microscopic particles, almost invisible to the naked eye, but they act as persistent irritants to the surrounding tissues. It's a persistent concern because, despite remarkable advances in implant materials, surgical techniques, and patient management, it remains the single most frequent cause for revision joint replacement surgery worldwide.
The single most frequent cause, still.
Yes. It inevitably leads to implant loosening, requiring patients to undergo further invasive procedures. And these revisions carry their own set of risks. They increase the healthcare burden and significantly impact a patient's quality of life.
Of course.
So it's not just an interesting radiographic finding. It's a critical, often debilitating clinical problem that we are still working relentlessly to overcome.
That historical context is really insightful, highlighting how our understanding has deepened from that sort of simplistic view of cement disease to this complex biological dance. So if we look at it radiographically, as you mentioned, how does osteolysis actually manifest on imaging? Do these distinct appearances tell us a story about its origins or the underlying processes at play? Are there specific fingerprints we can learn to recognize?
Absolutely. Fingerprints is a good way to put it. It's not just about seeing bone loss, but interpreting these unique patterns as direct clues to the underlying mechanism. Clinically, when we examine radiographs, we observe distinct patterns of periprosthetic bone resorption, that is, bone loss around the prosthesis. These aren't just random areas of bone destruction. They present in three primary, meticulously described patterns, and each offers crucial diagnostic and prognostic clues.
Okay, three primary patterns. What are they?
The first is linear osteosis. This appears as a fine, often continuous radiolucent line, meaning it appears dark on an X-ray, indicating less dense tissue right adjacent to the implant component.
Like a thin boundary line.
Exactly. This pattern typically tracks along the implant-bone interface, almost like a thin line of erosion. It suggests a more localized, perhaps circumferential, progression of the bone resorption process. The presence of this linear pattern often implies that wear particles are migrating along this interface, infiltrating the narrow space between the implant and the bone.
And triggering the inflammation right there.
Precisely. Triggering a localized inflammatory reaction that systematically erodes the bone boundary. It's like a slow, steady erosion, often hinting at particle dissemination along a pre-existing pathway.
Okay, that's linear osteolysis. What's the second pattern?
The second pattern is expansile osteolysis. Here, the bone loss appears to actively expand into the surrounding tissue, creating larger, more irregular lytic lesions. These often look like growing bubbles or cysts or even large amorphous defects within the bone around the implant.
So much more destructive looking volumetrically.
Yes, quite. This expansile nature strongly implies a more aggressive, perhaps contained, inflammatory response that is actively eroding significant volumes of bone. Unlike linear osteolysis, which seems more interface-driven, expansile lesions suggest a more concentrated inflammatory reaction, often originating from a nidus, a sort of hotspot of high particle concentration that then propagates outwards.
Right.
This can lead to substantial bone defects, making subsequent revision surgery incredibly challenging due to the loss of structural integrity. It's less about a thin interface and more about a growing void within the bone itself.
That sounds particularly difficult to manage. And the third pattern.
And finally, we have stress shielding. Now, while this is still a form of bone loss, it's slightly different in its pathogenesis. It's primarily a consequence of biomechanical factors rather than direct particle-induced inflammation.
How so?
Stress shielding occurs when the stiff implant component bears too much of the physiological load that the bone would normally experience. According to Wolff's law, bone remodels in response to mechanical stress.
It adapts to the loads placed upon it.
Exactly. It strengthens where it's loaded and atrophies where it's not. If the stress is shielded or bypassed by a stiff implant, the adjacent bone undergoes resorption due to this lack of physiological stimulation. This can manifest as a more diffuse, often proximal bone loss around the femoral stem or other load-bearing components.
So the bone just weakens because it doesn't think it's needed.
In essence, yes. While it may not directly cause aseptic loosening initially, it can compromise bone stock over time, making it more vulnerable to particle-induced osteolysis later or complicating future revisions. So the existence of these distinct radiographic patterns strongly implies that different underlying mechanisms contribute to their pathogenesis.
Okay.
Linear osteolysis might suggest particle migration along an interface. Expansile osteolysis points to a more concentrated inflammatory reaction, and stress shielding highlights a biomechanical mismatch. Understanding these visual cues is essential not just for diagnosis, but crucially for unraveling the specific biological and mechanical processes at play. The critical takeaway here is that these patterns are not merely descriptive. They hint at the why behind the bone loss, guiding us towards the specific pathologies and informing our treatment strategies.
It sounds like each pattern is a diagnostic compass pointing to a different battlefield, each potentially requiring a tailored approach.
That's a very good analogy.
It's fascinating how those distinct patterns on an X-ray can tell such a clear story about what's happening at a cellular level. But for all those stories, the common villain seems to be these wear particles you mentioned. You've highlighted wear debris as the primary suspect. Can you paint a picture for us? At a microscopic level, what actually happens to create these tiny particles within an artificial joint? It sounds like a constant, almost unavoidable process in any moving system.
Indeed, wear is inherent and, to some extent, unavoidable in any articulating joint, whether it's the natural cartilage of our knee or an artificial implant designed for smooth movement. In orthopedic implants, where debris production occurs primarily through three well-defined mechanisms, all contributing to the constant generation of microscopic particles that ultimately drive osteolysis.
Okay, what's the first mechanism?
First, we have adhesive wear. This is often considered one of the most important mechanisms in the osteolytic process because it's directly related to the intimate contact of the bearing surfaces. It occurs at a microscopic level when implant surfaces momentarily adhere to each other. Imagine two highly polished surfaces in contact. Under load and movement, microscopic asperities, tiny peaks on one surface can bond or stick to asperities on the other.
Like microscopic Velcro.
Something like that, yes.
Yeah.
As the joint moves further, these temporary bonds are broken, causing material transfer or loss. Tiny fragments are literally pulled off one of the surfaces, often leaving behind a roughened area, which can then exacerbate further wear. It's like microscopic cold welding and then fracturing occurring millions of times over the lifespan of an implant.
Constantly creating these little fragments. What's the second way?
Secondly, there's abrasive wear. Think of this more like a cheese grater effect or a very fine sanding process. This happens when a harder, rougher surface scrapes off particles from a softer component. It's particularly common in bearing combinations like metal-on polyethylene implants, where the harder metal femoral head can abrade the softer polyethylene liner.
Right, the classic example.
Exactly. Surface roughness, whether from the initial manufacturing process, a microscopic defect, or even accumulated third-body debris, other particles floating around can significantly exacerbate this process. If there are other smaller particles already circulating in the joint space, they can also act as a third body, getting caught between the main articulating surfaces and causing additional abrasion. This constant scraping literally shaves off material particle by particle.
So you can get wear causing more wear, essentially.
Precisely. It could be a self-perpetuating cycle.
And the third mechanism.
And finally, we have fatigue wear. This results from the repetitive stresses of cyclic loading and unloading that artificial joints experience during daily activities like walking, standing, or climbing stairs.
Just the wear and tear of everyday life.
Exactly. Every step, every movement imparts a load on the implant. Over time, these continuous microscopic stresses lead to the accumulation of damage and microscopic fractures within the implant material itself, often without visible deformation. Imagine bending a paperclip back and forth repeatedly until it eventually breaks on a much smaller, microscopic scale. That's what happens within the implant material, leading to the gradual generation of particles.
I see.
Patient activity levels, body weight, and the specific implant design heavily influence the extent of fatigue wear, as higher loads and more frequent cycles accelerate this process. This mechanism highlights the biomechanical stress environment the implant must endure.
It sounds like a constant battle against friction and stress, a really dynamic environment where many factors are at play, each contributing to this insidious process. What are the key factors, then, that influence the sheer amount of wear debris generated? Because presumably, more debris means a higher risk of osteolysis and eventually a greater chance of implant failure, right?
Absolutely. You've hit on a crucial point. The sheer quantity and also the characteristics of the debris are paramount, as they directly correlate with the inflammatory response and subsequent bone loss. Several critical factors dictate debris production, and these are areas where we, as orthopedic surgeons and material scientists, focus our efforts to minimize wear and thus enhance implant longevity.
Hi, what are they?
Firstly, material properties are paramount. The inherent composition, hardness, surface finish, and even the crystalline structure of the implant materials are directly related to their wear resistance. Strong metal alloys like cobalt, chromium, or titanium are chosen for their mechanical strength and stiffness. Polymers, so typically ultra-high molecular weight polyethylene or UHMWPE, are used as a bearing surface for their low friction and biocompatibility.
Right.
The specific interaction between these chosen materials, for instance metal on polyethylene versus ceramic on ceramic, significantly influences the type and quantity of wear. Materials with lower surface energy tend to exhibit less adhesive wear, for example. Harder materials resist abrasive wear better.
Makes sense. What else?
Secondly, implant design is crucial. This encompasses the geometry of the bearing surfaces, their congruency, the surface roughness at the articulating interface, and how the components articulate against each other. Engineers meticulously design implants to minimize friction and debris generation. For instance, increasing the congruency between the femoral head and acetabular liner can distribute load over a larger area, reducing contact stresses and thus wear.
So the shape and fit are critical.
Absolutely. The method of fixation, whether cemented or uncemented, can also influence micromotion at the bone implant interface, which in turn affects wear, especially for non-articulating components like the stem. Optimized designs aim for stability and low friction.
Okay, materials and design. What about the patient?
Thirdly, patient factors introduce a significant variable that surgeons constantly grapple with, as they are often beyond our direct control. A patient's activity level is a major determinant.
More active means more wear.
Generally, yes. A younger, more active individual will subject the implant to more cycles of loading and articulation, naturally increasing wear rates over their lifetime. Increased body weight also translates to higher contact stresses within the joint, accelerating both adhesive and abrasive wear. Even a patient's underlying bone quality can play a role, influencing the stability of the implant bone interface and thus potentially micromotion and wear generation.
So these are things you have to weigh up when choosing an implant and advising patients.
Definitely. These factors must be carefully considered during patient selection and subsequent postoperative counseling to manage expectations and advise on appropriate activity levels.
And you mentioned volumetric wear earlier.
Yes, and finally, volumetric wear is perhaps the most direct determinant of the actual number of particles created and therefore the total biological burden. It's not just about how much material is lost linearly, but the total volume of debris.
Why is that distinction important?
Because in hip arthroplasty, for example, volumetric wear is directly related to the square of the femoral head radius multiplied by linear head wear.
The square. So size really matters.
It really does. The femoral head size is a highly important factor in predicting particle generation. Larger femoral heads despite offering some advantages in stability, generate a significantly greater volume of wear debris for the same linear wear due to that squared relationship.
Wow.
This means even a small increase in head radius can lead to a disproportionately large increase in particle volume. Conversely, linear wear, which is typically measured as the distance the prosthesis penetrates into the liner, say, polyethylene penetration is a key clinical indicator. Rates exceeding zero point 0.1 millimeters per year have been strongly associated with osteolysis and subsequent implant loosening.
So that's a key threshold to watch for and follow.
It is. It guides our monitoring of patients post-surgery, helping us identify those at higher risk who may require closer follow-up. It's a continuous, dynamic interplay of all these factors.
That really helps us understand how debris forms and the various factors at play, from the microscopic physics of wear to the macroscopic influences of patient lifestyle. Really complex. Now let's turn to the materials themselves. We use a variety of materials in joint replacements today: polyethylene, ceramics, metals. Do they all contribute to osteolysis in the same way, or do we see specific issues or types of biological responses with certain materials? Because it seems the type of particle, its chemistry, its shape, its size, would profoundly influence the body's reaction, wouldn't it?
That's a crucial point. And no, their contributions vary significantly. The specific particle type, their average size, their morphology or shape, the total volume generated, and even their chemical composition, all profoundly influence the biological response. They drive different and often unique inflammatory cascades.
Okay.
Understanding these material-specific nuances is vital for both implant design and clinical management.
Right. Let's start with polyethylene, maybe. It's been around a long time.
Yes, polyethylene, specifically ultra-high molecular weight polyethylene, or UHMWPE, has been a cornerstone material in arthroplasty for decades. Conventional, non-cross-linked UHMWPE historically had wear rates typically between 0.1 and 0.2 millimeters per year. While widely used, its wear particles are a well-known potent cause of osteolysis.
But there have been improvements, haven't there, with cross-linking?
Absolutely. A significant innovation emerging from the late 1990s has been a highly cross-linked UHMWPE. This material is processed with irradiation and subsequent annealing or remelting. It generates significantly smaller wear particles and is inherently far more resistant to wear overall, typically showing linear wear rates 5 to 10 times lower than conventional UHMWPE.
That's a huge improvement.
It is. It dramatically reduces the particle burden. However, it's important to acknowledge a trade-off. Highly cross-linked UHMWPE can have slightly reduced mechanical properties.
Oh.
Well, compared to conventional non-highly cross-linked UHMWPE, it could potentially be more susceptible to other forms of failure, like fatigue cracking or delamination in certain circumstances, though its wear resistance remains superior.
Okay, so it's not a perfect solution, but much better on the wear front.
Generally, yes. Factors that increase UHMWPE wear in total hip arthroplasty include a polyethylene liner thickness of less than 6 millimeter, which leads to higher stresses component malalignment, patients under 50 years old.
Why younger patients?
Likely due to longer exposure time to the implant and generally higher activity levels over their lifetime. Also, male patients and those with consistently higher activity levels tend to show more wear. Interestingly, while larger femoral heads increase volumetric wear, the femoral head size between 20 to 46 millimeter in diameter does not seem to significantly influence UHMWPE linear wear rates.
Fascinating detail. Okay, what about ceramics? They're known for low wear, aren't they?
Yes, ceramics. These bearings, such as ceramic on ceramic or ceramic on polyethylene, boast the lowest wear rates among all bearing combinations, typically ranging from a mere 0.5 to 2.5 micrometers per component per year in ideal conditions.
Micrometers. That's incredibly low.
It is. This makes them highly attractive from a wear perspective, leading to minimal particle generation. However, ceramic on polyethylene bearings can show varied wear rates depending on the specific design, patient factors, and importantly, the quality of the ceramic surface. And there's a unique complication with ceramic bearings called stripe wear.
Stripe wear? What's that?
It can occur from specific gait patterns, particularly with what's called lift-off separation of the femoral head from the acetabular cup during certain phases of gait. This can cause very fine lead pencil-like markings on the ceramic surface.
Right.
When these markings develop, they lead to increased femoral head roughness and, in turn, can surprisingly cause significantly higher polyethylene wear rates in ceramic on polyethylene articulations, despite the overall low wear profile of ceramics themselves.
So even ceramics aren't immune to issues.
No material is perfect. Fracture is also a rare but potentially devastating complication of ceramic bearings.
Okay. What about metals? like cobalt chromium.
Right. Metals, primarily cobalt, chromium, and titanium alloys. Metal-on-metal, MOM systems, which gained popularity particularly in the early 2000s, generally produce significantly smaller wear particles compared to metal-on-polyethylene. Surprisingly, these systems can exhibit lower volumetric wear rates than conventional UHM-WPE, typically ranging from 2.5 to 5.0 micrometers per year.
Smaller particles and lower wear rates sound good initially.
Initially, yes. However, titanium, when used for bearing surfaces as opposed to structural components like stems, has historically shown a high failure rate due to its poor resistance to wear and notch sensitivity. It's prone to cracking.
Right.
But what's particularly significant and, well, concerning with metal-on-metal wear is its tendency to stimulate lymphocytes, leading to a more pronounced and widespread lymphocytic reaction in the surrounding tissues.
Lymphocytes, so a specific type of immune cell response.
Exactly. This can sometimes present with what we call perivascular cuffing, which means these immune cells are encircling blood vessels in the prosthetic tissues. This reaction can evoke a type IVT lymphocyte-mediated immune reaction, a delayed type hypersensitivity. The metal particle protein complexes act as happens.
What happens again?
They're small molecules that aren't immunogenic on their own, but when they bind to a larger protein, like one of the body's own proteins, the complex can trigger a significant immune response.
I see. And this reaction caused problems.
Yes, this type of reaction has caused considerable concerns, particularly with the more recent accounts of pseudotumors associated with some metal-on-metal implants.
Pseudotumors, what are they?
They're essentially sterile, fluid-filled, or solid masses that can develop around the implant in response to the metal debris and this intense lymphocytic infiltration. They can be quite destructive locally. Furthermore, metal-on-metal serum ion levels, which we can measure in the blood as an indicator of wear, are found to be greater when the cup abduction angle exceeds 55 degrees and with smaller component sizes.
So surgical technique and implant choice really matter there.
Critically important, yes. They can exacerbate the problem significantly.
And briefly, what about bone cement, PMMA?
Yes, finally, while not a primary articulating bearing surface, polymethyl methacrylate, PMMA, or bone cement, used for implant fixation, can also generate fragmented debris, particularly from the cement mantle itself. These microscopic fragments, perhaps from cement fatigue or fracture over time, can contribute to the overall particulate burden and exacerbate the osteolytic process, especially in older cemented designs or where the cement technique wasn't optimal.
So it adds to the total particle load.
It can do, yes. So as you can see, the specific material and the characteristics of the particulate it generates are profoundly important. While larger particles tend to provoke a more pronounced inflammatory response because they're harder for cells to clear, smaller particles, particularly those less than 1 micrometer in size, can be even more problematic.
Why is that?
Well, they can more readily infiltrate tissues, they're more efficiently phagocytosed or eaten by macrophages, and because of their incredibly high surface area to volume ratio, they seem to trigger very significant and sustained cellular responses. This underscores that it's not just the material itself, but its resulting wear particle characteristic size, shape, chemistry that truly drive the complex biological sequelae leading to osteolysis.
This is where it gets really interesting, isn't it? You've detailed how these wear particles of varying types and sizes originate from different materials. Now, once they're unleashed into the joint space, how exactly does the body react to them to actively cause bone loss? What's the intricate biological pathway here that leads to osteolysis, effectively turning the body's own defense mechanisms against itself? It sounds quite paradoxical.
You're right. This is the crux of the pathophysiology, where a response intended to be protective becomes profoundly destructive. When wear debris is introduced into the surrounding tissue, it's immediately recognized as foreign. This triggers a complex cascade of inflammatory responses, essentially a classic foreign body reaction aimed at clearing these particles, but which inadvertently leads to devastating bone destruction.
So the body is trying to clean up but makes things worse.
In this context, yes. At the heart of this response are the cellular participants. Macrophages are absolutely central. They are the body's professional cleanup crew and orchestrators of inflammation. They actively phagocytose, or engulf, the wear particles. This act of phagocytosis leads to their profound activation.
Okay.
And crucially, their activation leads to the recruitment of even more macrophages to the site of particle deposition through the release of chemotactic factors, chemical signals that attract more cells.
A gathering of the troops, as it were.
Precisely. Once activated and often engorged with debris, these macrophages become key secretors of a plethora of osteolytic factor substances that directly promote bone resorption. They transform from scavengers into powerful agents of bone destruction.
So, the macrophages are key players. Who else is involved?
Then we have osteoclasts, which are the undisputed primary bone-resorbing cells in the body. They are large, multinucleated giant cells, highly specialized for breaking down bone matrix. They are directly activated, and their formation is driven by the inflammatory environment created by the wear debris and the activated macrophages.
So the macrophages basically tell the osteoclast to get to work.
Effectively, yes. The cytokines and other mediators released by these macrophages create a microenvironment that is highly conducive to osteoclast differentiation from precursor cells, their maturation, and their sustained bone resorbing function. Interestingly, fibroblasts, osteoblasts, and lymphocytes are also consistently present in the chronic inflammatory infiltrate found in retrieved tissues from revised joints with osteolysis.
Even bone-forming cells like osteoblasts.
Yes. While macrophages are the main phagocytes, even fibroblasts, which are typically involved in tissue repair, and osteoblasts, the primary bone-forming cells, have been shown to be capable of phagocytosing wear particles. This highlights the widespread cellular involvement and the attempts by various cell types to deal with the foreign debris. Lymphocytes, particularly T lymphocytes, play that significant role in mediating specific immune responses, especially to metallic particles, as we discussed.
Okay. So these activated cells then release chemicals.
Exactly. Once activated, these cells, particularly the macrophages, significantly increase the transcription and relief of a plethora of pro-inflammatory substances, often referred to as cytokines and chemokines. These are the powerful chemical messengers driving the destructive process.
Which ones are most important here?
Key among these include tumor necrosis factor alpha, TNF-A, a potent inflammatory mediator known to directly stimulate osteoclast activity and bone resorption. Also interleukin-1, IL-1, and interleukin-6, IL-6, which are powerful drivers of inflammation, fever, and importantly promote osteoclast differentiation and activity.
So multiple signals pushing bone resorption.
Yes. Then there's interleukin-8, IL-8, a chemokine that acts as a powerful beacon, recruiting more inflammatory cells, especially neutrophils and monocytes, which become macrophages, to the site, thus amplifying the destructive cycle. We also see increased prostaglandins, such as PGE2, which play a crucial role in both inflammation and bone remodeling, directly stimulating osteoclasts and potentially inhibiting osteoblasts.
There's a double hit there.
Indeed. Plus reactive oxygen intermediates like nitric oxide and hydrogen peroxide damaging free radicals that contribute to tissue damage and cell death, and various metalloproteinases and lysosomal enzymes. These are proteolytic enzymes that directly degrade extracellular matrix components, including the collagen and proteins that make up bone.
So a whole cocktail of destructive chemicals.
It really is. What's truly fascinating and critical here is precisely how these mediators drive osteoclastogenesis, the formation of new bone-resorbing cells. For instance, an increase in TNF-alpha can upregulate RANK, or the receptor activator of nuclear factor kappa, on pre-osteoclast cells. Similarly, an increase in vascular endothelial growth factor, or VEGF, particularly when stimulated by UHMWPE particles, further enhances both RANK and its ligand, RANK and RANK.
Rank and rank.
But what do we know? These sound important.
They're absolutely central. This leads directly to what we call RANKL-mediated bone resorption. The receptor activator of nuclear factor kappa ligand, or RANKL, along with its receptor RANK, found on osteoclasts and their precursors, and the crucial decoy receptor osteoprotogerin, an OPG, forms a key axis in regulating osteoclast differentiation and activity.
Okay, so RANKL binds to RANK to activate osteoclasts.
Exactly. RANKL is the primary signal telling osteoclast precursors to differentiate and mature, and telling mature osteoclasts to get active and resorb bone.
And what does OPG do? OPG, osteoprotogerin, acts as a decoy receptor. It binds to RANKL, preventing it from binding to RANK. So OPG essentially puts the brakes on osteoclast activation and bone resorption.
Ah, okay. So it's a balance between RANKL and OPG.
Precisely. In healthy bone remodeling, there's a tightly regulated balance between RANKL and OPG. Wear debris, through all those inflammatory mediators we mentioned, drives a profound imbalance in this delicate RANKL-OPG ratio. It significantly tilts the balance towards ANKAL, meaning much more go signal for bone resorption and much less stop signal from OPG.
So the wear particles just slam on the go pedal for bone destruction while simultaneously releasing the brake.
Precisely. That's an excellent way to summarize it. The higher the ANKAL to OPG ratio, the more powerful the destructive signal, leading to more osteoclasts and more bone loss.
And that mechanism is so fundamental that targeting it is a therapeutic strategy.
Yes, it represents a significant therapeutic avenue, which we can discuss later.
Okay, so it's not just a localized event then. You mentioned recruitment. This sounds like it could be a systemic response involving more than just the cells immediately around the implant.
That's right. It's absolutely not simply a localized event confined to the immediate vicinity of the implant. This process has systemic implications. Recent animal models, employing sophisticated molecular tracing techniques, have clearly demonstrated that wear debris stimulates a systemic immune reaction.
How does that manifest?
It means that particles don't just sit there provoking a local response. They can lead to the mobilization and trafficking of remote macrophages, immune cells from other parts of the body, like the bone marrow or spleen, traveling to the specific area of particle deposition around the implant.
So cells are being called in from afar?
Yes. Macrophage chemotactic protein 1, or MCP1, appears to play a critical role in this chemotactic response, acting as a powerful biochemical come-hither signal that draws these macrophages to the inflamed site. Studies have even shown that the depletion of macrophages in these experimental models significantly diminishes this systemic immune response and consequently reduces the extent of osteolysis.
Which really highlights the importance of macrophages in the whole process.
Absolutely. It points towards potential therapeutic avenues where we might modulate not just the local, but also the systemic inflammatory and recruitment response.
Interesting. And beyond just the particles themselves triggering this cascade, what role do other factors play? Are there things that amplify the problem?
Yes, other factors certainly co-contribute, often in a synergistic, almost conspiratorial manner. Prosthesis micromotion is a key one.
Tiny movements of the implant.
Exactly. Minute movement at the bone-implant interface. This can occur if the implant isn't perfectly stable immediately after surgery, or if initial fixation isn't robust, perhaps due to surgical technique or poor bone quality. Even seemingly insignificant micromotion, measured in micrometers, significantly increases particle wear. Imagine even minute rubbing at the interface. These movements literally generate more particles, further propagating the osteolytic cascade.
So instability creates more debris, which causes more bone loss, leading to more instability, a vicious cycle.
Precisely. You can rapidly accelerate further bone loss and ultimate implant failure. It transforms a stable environment into a high-friction, high-wear zone.
What else contributes?
Also, the presence of endotoxin on particles can play an important exacerbating role. Endotoxins are lipopolysaccharides from the outer membrane of gram-negative bacteria.
Bacteria. But surgery is sterile.
Ideally, yes. But while implants are placed in a sterile environment, very low-level subclinical bacterial contamination or the translocation of bacterial products from, say, the gut might potentially occur. These endotoxins act as incredibly powerful immune activators, further stimulating the inflammatory pathways already activated by wear particles, amplifying the overall destructive response. They essentially prime the macrophages to be even more aggressive.
Like adding fuel to the fire.
Exactly. It's probably most useful to consider these as co-contributory factors rather than entirely separate entities, as they often interact and amplify each other. Furthermore, an increase in hydrostatic pressure within the effective joint space, which is a direct result of the inflammatory response and the accumulation of fluid, also contributes to the dissemination of debris.
How does pressure spread debris?
This increased pressure can literally push wear particles into previously unaffected areas of the bone, or deeper into bone marrow spaces, further propagating the osteolytic process away from the immediate implant interface. It helps the particles travel. So it's a dynamic and multifaceted interaction between the particles, the body's sophisticated yet sometimes misguided inflammatory machinery, and biomechanical factors like micromotion, all conspiring to erode bone integrity.
It's a really complex picture. This cellular and chemical cascade is clearly driving bone destruction, leading to the resorption we see in osteolysis. But does wear debris also impact the body's ability to build bone? Because if it's both destroying existing bone and simultaneously inhibiting the body's natural capacity for repair and formation, that's a true double whammy for bone integrity around the implant, isn't it? Making the problem far more intractable.
This raises an incredibly important question, and the answer is indeed yes. It's a significant double whammy for bone health around the implant. Unfortunately, wear particles not only stimulate bone resorption by activating osteoclasts, but also actively interfere with bone formation.
So they stop the repair process too.
They actively hinder it. This dual negative impact is a crucial aspect of why osteolysis progresses so relentlessly and why the resulting bone defects become so challenging to manage during revision surgery. Studies, both in vitro, in lab cell cultures, and in vivo, in sophisticated animal models, have clearly shown that both metallic and polymeric particles inhibit the proliferation, differentiation, and overall function of crucial cells involved in bone regeneration.
Which cells are affected?
These include mesenchymal stem cells, which are the precursor cells that can become bone-forming cells, osteoprogenitor cells, which are more committed to becoming osteoblasts, and the osteoblasts themselves, the primary bone-forming cells responsible for laying down new bone matrix.
Well, the whole production line for new bone is disrupted.
Effectively, yes. It means that even as the body attempts to repair the damage or maintain bone homeostasis, the persistent presence of wear particles actively sabotages these efforts, preventing new bone from being laid down effectively. This adverse effect has also been demonstrated in animal models looking at bone ingrowth, the critical process by which native bone grows directly onto the porous surfaces of uncemented implants for long-term stability. The presence of wear particles significantly impedes this ingrowth.
Making it harder for the implant to integrate properly in the first place or stay integrated.
Exactly. It highlights a comprehensive negative impact on bone homeostasis. And adding another layer of complexity to this pathophysiology, recent research also indicates that endoplasmic reticulum, ER stress, plays a crucial role in this osteogenic impairment induced by wear particles.
ER stress, what is that in this context?
The endoplasmic reticulum is a vital organelle within cells responsible for protein folding and transport. When cells are under stress, for example, due to engulfing foreign particles, misfolded or unfolded proteins can accumulate in the ER, leading to ER stress. The cell tries to cope via the unfolded protein response, UPR. However, if this stress is prolonged or severe, the UPR can switch from being protective to promoting cell death or apoptosis.
So the stress kills the bone-forming cells.
It can do. Specifically, the Perk-Shop axis, a particular signaling pathway within the UPR, has been identified as a critical pathway leading to the apoptosis of osteoblasts during ER stress triggered by wear particles.
Wow. So wear particles not only inhibit the function of bone-forming cells, but can actually trigger their programmed death.
Precisely. This truly demonstrates a comprehensive disruption of bone remodeling, shifting the balance dramatically towards net bone loss, making recovery and repair incredibly difficult. It's a formidable challenge at the cellular level.
That paints a stark yet incredibly clear picture of the devastation osteolysis can cause, from the simple mechanics of wear right down to the intricate cellular sabotage. Given its profound and often debilitating impact on patients, leading to complex revision surgeries, what are the current therapeutic strategies being explored to combat osteolysis? And perhaps more importantly, what does the future hold for prevention and treatment? Where are the horizons for orthopedic innovation here?
It's a significant and very active area of ongoing research, as the clinical need, as you say, is immense. It's important to state up front, though, that currently there are no FDA-approved non-surgical pharmacological therapies widely available for the general clinical treatment of aseptic loosening caused by osteolysis.
Still no approved drug treatment.
Not specifically for this indication, no. This underscores the urgent and unmet need for viable, effective solutions that go beyond the current gold standard, which remains revision surgery, an invasive procedure with its own significant risks and challenges.
Right. So what is being investigated?
Several therapeutic strategies are vigorously under investigation, ranging from natural compounds to highly advanced biotechnologies, each targeting different aspects of the osteolytic cascade we've discussed.
Okay, like what?
Well, firstly, natural compounds. Some natural compounds have shown intriguing promise in preclinical studies. For instance, Ostol, OST, a coumarin derivative found in traditional Chinese medicine.
Osshole.
Yes. It has demonstrated beneficial osteogenic properties, meaning it can actively promote bone formation. Crucially, it also appears to be able to modulate that endoplasmic reticulum, ER, stress adaptation we just talked about.
Wow, so it could protect the bone-forming cells?
Potentially, yes.
Yeah.
Ostol seems to help cells cope with ER stress, thus protecting osteoblasts from impairment and apoptosis caused by wear particles. This dual action promoting bone formation and protecting osteoblasts makes it a fascinating avenue for research, though it's still in very early stages.
Interesting. What about targeting that iodine KL pathway you described?
It's exactly. Given Arenkel's central dominant role in driving osteoclastogenesis and bone resorption, pharmacological Arenkel inhibitors represent a highly logical potential treatment modality.
Blocking the go signal.
Precisely. By blocking that specific signal for osteoclasts, we could theoretically reduce osteoclast activity and thus slow down or halt bone loss. Bisphosphonates, a class of drugs commonly used for osteoporosis drugs like alendronate or zoledronate.
Yes, familiar drugs.
They have already shown efficacy in mitigating particle-induced bone loss in experimental settings. They work by inhibiting osteoclast activity and have the advantage of high uptake in skeletal tissues, meaning they concentrate where needed.
So why aren't they routinely used for osteolysis?
Well, while systemic use for established osteolysis has been explored, challenges remain regarding optimal dosing, the potential for side effects with long-term systemic use, the effectiveness once significant bone loss has occurred, and perhaps the need for more localized delivery. Research is ongoing into localized delivery systems or specific bisphosphonates tailored for periprosthetic use.
Okay. What other approaches? Modulating inflammation.
Yes, inflammatory response modulation. Since inflammation is at the very core of the problem, modulating this exaggerated immune response is another logical approach. Experimental treatments like local administration of interleukin-10, IL-10, which is a potent anti-inflammatory cytokine, or anti-TNF cytogene therapy, have shown promise in inhibiting the resorptive response to wear particles in preclinical models.
Trying to calm the storm locally.
Exactly. These approaches aim to dampen the inflammatory cascade directly at the source. However, the multifactorial nature of the inflammatory response, with so many different mediators involved, presents significant challenges for widespread clinical application.
It's not just one target.
No. Delivering gene therapy safely and effectively to the joint space without off-target effects and ensuring sustained expression are major hurdles. Targeting just one cytokine might not be sufficient, or it might have unintended systemic side effects. It's complex.
And looking further ahead, more advanced therapies.
Yes, looking further into the future, the field is exploring highly sophisticated methods. This could include targeted delivery of signaling molecules directly to the affected bone microenvironment, perhaps using nanoparticles or injectable hydrogels to ensure precise delivery and prolonged action. Advanced gene editing techniques such as CRISPR-Cas9 could potentially be used one day to modify specific cellular responses.
Right.
Maybe you're programming macrophages to be less osteolytic or enhancing the resilience of osteoblasts.
Really cutting-edge stuff.
It is. And the burgeoning field of engineered exosomes, tiny vesicles naturally released by cells, offers promise for RNA molecule delivery to regulate gene expression, essentially delivering therapeutic instructions directly to the cells involved. These approaches aim to precisely modulate the bone microenvironment and enhance its regenerative capacity, moving towards highly specific biological interventions. But it must be said, they are still largely in the realm of basic science and early preclinical development.
Fascinating potential, though. But what about prevention? Surely stopping it before it starts is key.
Absolutely. Prevention and mitigation strategies are equally critical, aiming to reduce the problem at its source or prevent its onset altogether.
How can we do that?
One novel avenue is targeting ER stress in prevention, modulating the unfolded protein response, UPR, to mitigate the harmful effects of prolonged ER stress, offers a potential way to prevent aseptic loosening from the outset.
Protecting those osteoblasts early on.
Exactly. If we can protect osteoblasts from dying or becoming dysfunctional due to wear particles, we can potentially maintain the bone integrity that is essential for implant longevity. Research here involves identifying specific small molecules that can modulate the UPR safely.
What about improving the implants themselves?
Hugely important. Advanced bearing surface designs are paramount and continue to evolve rapidly. This includes further development of ultra-high molecular weight polyethylene bearings with enhanced durability and wear resistance, like the next generation of highly cross-linked polyethylenes, some incorporating antioxidants like vitamin E for stabilization.
Vitamin E. How does that help?
It helps to quench the free radicals created during the irradiation process used for cross-linking, which can otherwise lead to long-term oxidation and degradation of the polyethylene, potentially increasing wear later on.
Ah, clever.
And crucially, addressing how polyethylene is sterilized is also vital. Traditional radiation sterilization in air can unfortunately lead to oxidation. Newer methods, such as using sealed packages with inert gases like argon or nitrogen, or using gas plasma or ethylene oxide for sterilization instead of high-dose radiation, prevent this oxidation and significantly reduce wear debris generation. This leads to dramatically improved long-term performance.
So manufacturing and processing really matter.
enormously. Another area is coating technologies. Applying advanced coatings to implant surfaces plays a significant role in improving performance and reducing wear and corrosion. For example, titanium dioxide, TiO2 coatings, can act as a protective barrier against corrosion, especially for metallic components, reducing the release of potentially problematic metal ions. Diamond-like carbon, DLC, coatings can be applied to articulating surfaces to significantly minimize friction and wear by creating extremely hard and smooth surfaces, thereby extending implant lifespan.
Like making the surfaces super slippery and tough?
Essentially, yes. Continuous research aims to further enhance these coatings, perhaps incorporating bioactive properties to promote bone integration while simultaneously reducing particle generation.
And you mentioned 3D printing earlier. How does that fit in?
Well, 3D printing in orthopedic surgery is truly transformative. This technology allows for the creation of customized implants and even patient-specific surgical tools tailored precisely to an individual patient's anatomy.
Personalized implants.
Exactly. This can significantly improve surgical success rates by optimizing the fit and alignment of the implant within the bone. A perfectly fitting implant will experience less micromotion and more physiological load transfer.
Which means less mechanical wear generation.
Precisely. Furthermore, 3D printing allows for the creation of complex porous structures on the implant surface that actively encourage natural bone ingrowth, enhancing biological fixation and potentially making the implant more resilient to the stresses that generate wear. It's moving us towards truly personalized medicine in orthopedics.
That sounds incredibly promising.
It is. The challenges remain, of course, in translating these promising laboratory findings into widespread clinical practice through robust, large-scale, long-term clinical trials. That's always the bottleneck. And critically, developing personalized treatment strategies, perhaps leveraging artificial intelligence for patient stratification, identifying which patients are at highest risk of osteolysis, or would best respond to certain interventions based on their genetics, activity levels, or even specific inflammatory profiles.
Using AI to predict risk and tailor treatment.
That's the hope. But the continuous evolution of materials, our deepening biological understanding, and these advanced manufacturing technologies offers real hope for significantly enhancing patient care and outcomes in orthopedic surgery. We're moving closer to truly long-lasting and hopefully complication-free joint replacements.
Profi Mom, that was an absolutely brilliant deep dive into osteolysis, really comprehensive. We've gone from its historical recognition and those radiographic patterns through the intricate cellular and molecular mechanisms that drive bone loss, and now right to the exciting cutting edge of prevention and therapy. It's clear this is a field constantly evolving, driven by that profound and essential need to improve long-term patient outcomes in arthroplasty.
It certainly is. There's still much work to do, but progress is definitely being made.
For you, our listeners, we hope this deep dive has offered clarity on what is clearly a complex but vital topic. We hope it's giving you a comprehensive understanding of the challenges and also the exciting innovations in managing paraprosthetic bone loss. If you found this discussion valuable, please do consider leaving us a rating and perhaps sharing this deep dive with a colleague who might also benefit from this insight. Thank you again for sharing your profound expertise and insights with us today. It's been incredibly enlightening and truly brought this complex subject to life.
My pleasure. Thank you for having me.
And to you, our listener, we leave you with this thought. As orthopedic technology advances and our understanding of the body's subtle cellular responses to implants deepens, how might this newfound knowledge pave the way for truly bio-integrated solutions, moving beyond mere mechanical replacement towards implants that actively foster and protect bone health for a lifetime? Until next time, keep exploring, keep learning.